Good afternoon, everyone, and welcome to our webinar focusing on approved and investigational treatments for AL amyloidosis. All of our previous webinars can be viewed on our on the webinar section of our website, amyloidosissupport.org, and also on our YouTube channel. This webinar should be up there in a week or two. Some of you sent in questions ahead of time, and we'll get to those after our presentations, and we'll also, you can enter questions in the Q&A, and we'll get to those as well. Any that we don't get to, we'll ask our doctors to please fill out answers and send them to you after the webinar is over. The chat portion has been disabled, but Bob will be occasionally putting up some useful items and links for you. Our esteemed panelists today include Dr. Othman Akhtar from Frontline Hospital in Milwaukee, and Dr. Jeffrey Zonder from Karmanos in Detroit. Good-looking group of men. Oh, I shouldn't say that, right? Okay. Anyway, you'll be seeing our brilliant doctors that I just mentioned at some in-person meetings coming up, as well as other faces we all know and love. Our meeting calendar is on our website, and we have a meeting coming up in St. Louis, March 15th. On March 22nd, we're going to be in Duke in North Carolina. We'll be in Fairfax, Virginia, April 5th. And April 26th finds us in Philadelphia and Portland, Oregon. We're also working on meetings in several other cities. We do email out information on meetings as well as post them in our Facebook group, and they're always up on our website under the link for amyloidosis meetings. There will be a brief survey when this meeting is over, and we do ask that you take the time to fill it out. Should you have to leave early, we ask that you fill it out when you leave. It's important to us, and it will help us in developing future webinars. We'll be working off our treatment chart today, and Bob is going to put it on the screen for your reference. And it's kind of exciting that the producer of the treatment chart is one of our guest doctors today, Dr. Zonder. Okay, you can feel free to email me at Muriel at amyloidosissupport.org for a copy of it, and Bob's going to put a link up in the chat for you to access it as well. Okay, speaking of Bob, Bob is our director of special projects, and he's in our control room today. Bob, say hi.
Hello, everybody. And I did put the link up for the treatment chart in the chat, so you can access the link and download it directly from our Google Drive.
Okay, Paula is absent today, but she did pre-record for us a presentation about financial aid, and so Bob will be playing that for us. We're going to hear from Dr. Akhtar on standard of care treatments, upfront therapies, etc. Take it away.
Yep, I'm right here. So I'll share my screen. Just give me 1 second here. Are you guys able to see the screen?
Yes, it's not in presentation mode.
No, it won't be. Not
there
yet.
you go.
Yeah, there we go. All right, perfect. Well, now I'm assuming you can see the screen and you can hear me well, correct?
Correct.
Okay, lovely. All right, so good afternoon, everyone. My name is Othman Akhtar. Thank you, Muriel, for pronouncing that correctly. I am an assistant professor. I'm a hematologist oncologist at the Medical College of Wisconsin and the Frontline Cancer Center in Milwaukee, in Wisconsin. It's a great pleasure and honor to be here. And what I'm going to do today, these are my disclosures. What we're going to do today is we're going to talk a little bit about the frontline treatment of AL amyloidosis, what the current standard of care is, and I'll talk to you briefly about one of the important ongoing trials in the frontline treatment of AL amyloidosis. But before we do any of that, I'll quickly go through some of the pathology underlying amyloidosis to help you understand why we are doing what we're doing and why we do what we do essentially. Now, I understand that many of you are probably already familiar with this, but just a quick recap for those who are not. Amyloidosis is basically a condition where certain proteins in the body take on an abnormal shape, they're misfolded, and as a result, the body is unable to degrade them, and they start to pile up and affect different organs like the heart, the kidneys, or the nerves. The clinical presentation really depends on what type of protein is misfolding. Our focus today is going to be on AL amyloidosis. So before we understand what goes wrong to cause AL amyloidosis, I think a quick primer on the normal function of plasma cells is very helpful. So plasma cells are part of our immune system. We all have them. When we are exposed to an infection, these cells are very important in helping us fight off an infection. And the way they do this is they divide, they make these proteins called antibodies, and they spill out a few light chains. These are like antibody parts. And once the infection has been neutralized, these cells essentially die off, and your antibody or immunoglobulin levels return back to normal. So this is what happens under normal circumstances. What happens in AL amyloidosis is, number one, for reasons that are not exactly clear, these plasma cells acquire a mutation that allows them to divide uncontrollably. So there's no infection, there's no stimulus. They're just dividing, dividing, dividing. And they're making a ton of antibodies and abnormal light chains that gradually accumulate over time. So these are faulty light chains. The body looks at them and it doesn't know what to do with them. It doesn't know how to degrade them. And then over time, what we see is that these faulty light chains pile up in different organs and start causing damage. The most frequent organs being the kidneys, the heart, the nerves, but really any organ can be affected in AL amyloidosis. So the question then is, how do we treat AL amyloidosis? What are the treatment goals? So the first thing we want to do is we want to turn the tap off. And the way we do that is by trying to kill amyloid making plasma cells to basically immediately reduce amyloid production. And our goal is to try and do this as quickly and as completely as possible. In medical jargon, the term we use to assess how well we're doing this is hematological response. Many of you might be familiar with this. You might have heard about this in different presentations, or you might have even heard your physician, your oncologist or hematologist talk to you about this. What this basically is telling us is how well have we reduced the abnormal protein that the plasma cells are making. So that is essentially what a hematological response is. In the short term, the goal of doing this is immediately preventing any further organ damage. And then over time, often several months, the idea is to give the body the opportunity to heal and try and reverse some of this organ damage, something that we call organ response. And we're going to be talking about organ response in a little bit. So the next question is, how do we kill plasma cells? Now we're very fortunate in the myeloma world and the AL amyloidosis world that a number of drugs have been discovered, a number of drugs have been developed over time that are very, very effective killers of abnormal malignant plasma cells. And through years of research and many clinical trials later, we have learned how to combine these drugs into basically cocktails that are not just effective at treating the clone in patients with amyloidosis, but are also safe in patients with amyloidosis who often have so many other medical problems because of the disease. This is a slide that Dr. Zonder prepared. I actually just learned. I want to acknowledge him. And this kind of tells you what our amyloid toolbox looks like. This is from 2024. I know we're now in 2025, but this is a fairly updated representation of our repertoire, of our toolbox. The 4 drugs that we currently combine as part of our frontline management are the abbreviation we use for them is DARA D. This regimen was approved by the Federal Drug Administration in I think January of 2021 for the frontline treatment of amyloidosis. We'll talk in a few minutes about how we got there, but it's basically 4 drugs. The first drug on that list is daratumumab. This is basically an antibody that tags plasma cells. And when it tags plasma cells, it basically invites your own immune system to attack and kill them. Cyclophosphamide is a chemotherapy drug. It's an old school chemotherapy drug that is toxic to plasma cells. It causes damage to the DNA and it essentially forces the cell to kill themselves. Bortezomib or Velcade, Velcade is the brand name. Bortezomib is a proteasome inhibitor. It chokes plasma cells. And dexamethasone is a steroid that is also toxic to plasma cells through a very complex mechanism that's beyond the scope of our talk today. So how did we get here? So for many years, we have known that bortezomib-based regimens, bortezomib being the bore here, were very effective in patients with amyloidosis. And several years ago, studies showed that when you combine it with a chemotherapy drug called cyclophosphamide and some steroids, you can actually achieve responses in a substantial number of patients. Though a vast majority of times, those responses were not complete responses. So what we were able to do and what we were achieving was a very significant reduction in how much protein was being made, but only about 20 to 25% of the times were we getting to a point where there was no abnormal protein being detected. So the question that the Andromeda trial asked was, well, what if we add this new drug that we've just come up with, daratumumab, to our current standard of care regimen, CyBorD, and let's see what happens. Let's see if this improves outcomes in AL amyloidosis. And their primary endpoint was a complete hematological response. We'll talk about that in a moment. So how did they design the trial? This is the kind of important to understand because this is kind of set the template for how we treat AL amyloidosis today. So what they did is they took patients, almost just under 400 patients, randomized them into two groups. The CyBorD group got 6 cycles of this old chemo regimen. I'm going to use the word old here. And then the Dara plus CyBorD group got daratumumab combined with CyBorD again for 6 cycles. And then they went on to receive another 18 cycles of daratumumab maintenance, which is about another 18 months worth of treatment for a total of 2 years of treatment. Before they did the trial, the FDA required the company or the group to basically do a safety run-in, which means that they just wanted to make sure that this combination is safe, that it wasn't actually causing more side effects, given how sensitive amyloid patients can be. And they confirmed this, and eventually the trial ended up enrolling in about 109 different sites across 22 countries. So what they found was quite remarkable. Around half of the patients in the data CyBorD group achieved a complete heme response, which means that using standard laboratory techniques, you're not able to detect abnormal protein circulating in the blood. This was compared to just under 20% in the CyBorD group. So you're more than doubling the response, the complete hematological response by using this drug. Around 40 to 50% of patients had a heart or kidney response, compared to just around 20% in the CyBorD group. The median time to hematological complete response was 60 days, which means, in other words, the people who were responding very quickly. And we talked about how that's a very important that's a very important element, a treatment goal is try not just getting to a response, but trying to get to it fairly quickly to limit any further organ damage. I also want to highlight here that the 50% that we're talking about here is a complete hematological response, but around 80% of patients did have a very significant reduction in the abnormal protein, something that we call a very good partial response, where you see a 90% reduction in the difference between the abnormal and normal light chains. We're always concerned that, all right, what people might respond but eventually relapse. But again, what you see is that with this treatment, there was a significant reduction in the chances of progression, not just of the clone, but also in the heart and the kidneys. In other words, 2/3 less patients actually progressed. Well, what about survival? So, sorry. Um, Interestingly, this study had a median follow-up of around 11-ish months when this paper was published in the New England Journal a few years ago. There was no difference in overall survival or early deaths in the two arms. You can see that over time there was a difference in what we call major organ deterioration, hematologic progression, or death. What this basically says is that patients are living without their organ function significantly deteriorating or their light chains going up or without dying, basically. But I really do want to point out here that yes, we're seeing great response rates and we're seeing patients do so much better. But unfortunately, you can see that there was no difference in early deaths between the two arms. And as a hematologist taking care of patients with amyloidosis, this is sobering because it tells me that there is a group of patients where we need to do a little more than just dara-CyBorD. We're still very much at risk of complications early in the treatment. The first question that I get from all my patients starting this treatment is, well, what side effects can I expect with this treatment and with this regimen? Um, to begin with, I think it's important to recognize that adding daratumumab to the older regimen that we used did result in a few more infections and low blood counts, but generally speaking, the side effects were balanced between these two groups on the trial. But to answer my patients' questions, I tell them that it's very common to have swelling, to have GI side effects, nausea, diarrhea, constipation. Often people will have a worsening of heart failure. But in reality, it's kind of challenging sometimes to distinguish between treatment and disease-related complications in amyloidosis. I always tell my patients that supportive care and timely management of these side effects is a very, very, very important part of their care. We have a team here. I always work very closely with my nephrology and cardiology colleagues for patients who also have cardiac amyloidosis or renal amyloidosis. It's very, very important to be on top of these side effects. I tell my patients to be proactive, not to be shy to call us, not to be shy to reach out, because our goal is we want you to live longer. We also want you to have an excellent quality of life. I'm not going to go through how I manage or how we in our group manage these side effects. That's a talk in itself, but I do want to highlight some of these side effects that we see with this treatment. So to quickly summarize everything and make sure that we're all on the same page, treatment of AL amyloidosis basically involves the killing of the abnormal plasma cells that are making the amyloid. Dara-CyBorD followed by Dara maintenance is now the current standard of care. Almost 80% of patients will at least achieve a very good partial response, with just over half of patients experiencing a complete hematological response. 40 to 50% of patients can also expect an organ response with improvement in their heart numbers, labs that we draw to see how damaged the heart is and the kidney numbers. But despite this, we still have many unanswered questions. These questions were not answered by Andromeda. And I think for me, the first question is, do we really need maintenance therapy for another 18 months, especially in patients who have achieved a complete hematological response quite early? In multiple myeloma, which is also a disease that is caused by plasma cells, I think the answer is very clear that maintenance therapy improves outcomes. But in amyloidosis, I think the jury is still out there. I know many of my colleagues use maintenance, and some of my colleagues do not. They're still waiting for more evidence on this. And then again, how long does maintenance therapy need to continue? These are questions that were not answered by the Andromeda trial. And the last question is there still a role for high-dose chemotherapy and autologous stem cell transplant in this new era? Now, I'm going to talk to you a little bit about transplant because I want to put a plug in to a clinical trial, which I think is very important in an AL amyloidosis. We'll get there in just a moment. But for those of you who are not familiar already with stem cell transplantation, what is it and how does it work? So the real treatment in autologous stem cell transplant, which is the kind of transplant we do in amyloidosis, is actually the chemotherapy. So there is a chemotherapy drug called melphalan. And melphalan, high doses of melphalan, has the ability to basically wipe out plasma cells. But what it does in the process is it also kills a lot of the civilian cells, a lot of the good cells that live in the bone marrow that make important cells in the blood, like your red blood cells, your platelets. These are all things that you can see on your CBC. They're made inside the bone marrow, which is like a factory for the blood. And melphalan does not distinguish between enemy and civilian. It kills all alike. And so in order to be able to give this treatment, we needed to figure a way to rescue the bone marrow from these side effects. And we were very fortunate that we many decades ago discovered these special cells called stem cells. And I think of stem cells really like magic seeds. So these are magic seeds because think of it, if you have a garden, you have a seed for an apple tree, you have a seed for an orange tree, you have a seed for a bush, but they're all different seeds. But stem cells are like magic seeds that have the ability to give rise to all these different plants at the same time. So they basically help manufacture or lead to the manufacturing of all the important cells in your bone marrow, like white cells and red cells, etc. So what we do in patients receiving an autologous stem cell transplantation is we first collect the stem cells prior to chemotherapy. And then after we give patients melphalan, we'll infuse these cells back. And this process is basically called an autologous stem cell transplantation. So what is our approach at our center in terms of auto? We first try to enroll patients to this important national level study called the SWOG 2213. I just want to be very clear. I'm not a PI on this study. I don't have any personal, nothing personal on this study. I just think that this is an important trial, and we'll talk about it in the next slide. But for patients who don't or cannot enroll on the study, if we think that they're still candidates for transplantation at some point, we do try to collect their stem cells, usually after 3 to 4 cycles of treatment. The planning takes time. We need to get insurance approval, etc. So we do plan well ahead of time. And if patients have had an inadequate response to therapy after a few cycles, especially if they still have very significant light chain burden, oftentimes we'll just recommend proceeding to auto transplant. The idea being that this does deepen response and take patients to a hematological complete response. So what is the SWOG 2213? This is a randomized controlled trial that is now asking the next set of questions after the approval of DataCyber-D, which is, well, can we just continue with DataCyber-D, or do we need to do a transplant? Does transplant improve outcomes? So what they're doing is they're taking patients, treating them with DataCyber-D upfront for about 3 cycles. This is known as induction. Induction essentially means that we are sending our fighter jets to bomb everything around, clearing the space away before we plan our next consolidated step. So induction is where you're basically just treating patients with standard of care DataCyber-D for about 3 months. And then following this 3-month period, people are randomized into 2 arms. One group of patients will continue to get DataCyber-D and maintenance, and the other arm will go on to get melphalan, high-dose chemotherapy, and an autologous stem cell transplantation, followed again by maintenance therapy. The endpoint being the MOD-PFS endpoint that we talked about earlier. And if you want to know more about this trial and where this trial is open, this is a QR code that you can scan, and this is the link to the website, or you can just Google the SWOG 2213. And with that, I'd like to thank you all for the opportunity to speak here. Our program lead, Dr. Anita D'Souza, who's a world-renowned amyloidosis expert, and we are all really fortunate to have her. We learn from her every day, and to the amyloidosis support group that actually gave me the opportunity to speak today. With that, thank you all very much, and I think I'm going to have to go back to mute, right?
Thank you so much. That was wonderful. You can expect to hear from us in the future.
Pleasure. Yeah, absolutely. Anytime.
Okay, great. And stick around. There'll be lots of questions coming. Okay. And well, I guess we'll move the Paula financial aid presentation, Bob, to the end, because we've got Dr. Zonder, and he's going to be continuing with the therapies. We want to keep the flow going. Okay.
Right, that works.
So let us. Hello, Dr. Zonder. We'll let you take it away.
All right, I'm going to share my screen. Can you hear me okay?
Yes.
All right. How's that look?
Perfect.
All right. Muriel, thank you so much for the opportunity to speak. And that was an excellent first talk, a hard act to follow, but I am going to give it my best shot. My task today is to talk about therapies that we might think about after first-line therapy, and I'm going to focus on sort of novel therapies. There are some older plasma cell therapies that have been developed for multiple myeloma, like lenalidomide and pomalidomide, and older chemotherapy drugs, but I'm going to focus on these three things. I'm going to focus first on venetoclax, then I'm going to focus on a whole group of immune therapies called BCMA targeted therapies, and then I'm going to talk about a different sort of immune therapy called antifibril therapies. And I'm going to, again, using these charts, the first thing we're going to focus on is venetoclax. And venetoclax is a drug that targets something called BCL2, which is a protein in amyloid plasma cells that are important for those plasma cells' survival. And so if you inhibit that protein, it kills those cells. And it turns out that we know that this can be an effective drug killing plasma cells because this drug has been tested in multiple myeloma. Now, it's approved for some kinds of lymphoma and for chronic lymphocytic leukemia. So this is an FDA-approved drug, but it's not FDA-approved for any plasma cell therapy. But in multiple myeloma, it turns out if you have a specific genetic abnormality in your plasma cells where pieces of chromosome 11 and chromosome 14 swap material, okay? That's called a translocation. You might see that on a FISH report. When you have a bone marrow biopsy, you see a chromosome analysis and you'll see a FISH report, and the FISH report looks for some like specific genetic or molecular abnormalities, and one of them is this translocation 1114. And in multiple myeloma, about 15% of patients have this translocation, and this is the subset of myeloma patients that seem to benefit most from venetoclax-based therapy. And I think the potentially exciting thing in AL amyloidosis is that this particular abnormality, for reasons we do not understand completely, is about 3 times as common. And so you have a much bigger chunk of AL amyloidosis patients who could potentially benefit from venetoclax-based therapy. And we have a little bit of published data to help us, I think, believe that it might be helpful. So this is one of the earliest case reports, and it's only a little over 5 years old. And this is basically a graph of a single patient's journey with their amyloidosis. The red line is their kappa free light chain level, and each of the colored sections is a period of time when they were on a certain therapy. So their original therapy was Cybor-D, and then they got melphalan-based therapy, and then they got lenalidomide and daratumumab, and that takes us to the last 2 sections where the arrow is. And before that time, their light chains never normalized. But when they were treated with venetoclax and daratumumab together, after not normalizing their light chains with just daratumumab, suddenly their light chains normalized, and that was the first time that their kidneys and heart actually started responding. So they had gone through several lines of therapy just in the first 2 years, 1.5 to 2 years of their journey without ever normalizing their light chains until they had venetoclax-based therapy. So this is some evidence. Then we started seeing some case series. So this is a group of 11 patients, 12 patients rather, and to help you understand what we're seeing, I'm going to focus in on these bars here. This is called a swimmer's plot, and basically this is showing each bar is a patient over time, and it shows us sort of what happened with these patients. And so you can see that these red and green lines are the patients who achieved a complete response or a very good partial response to therapy. Overall, 7 out of 12 patients achieved this kind of a major response to venetoclax-based therapy. What's a little confusing here, and I'm going to show you another publication, some of these patients just got venetoclax, but some of them got venetoclax in combination with chemotherapy. So teasing out, like, what was the contribution of venetoclax is a little bit difficult. This is another study, bigger. This is over 40 patients with AL amyloidosis treated with venetoclax-based therapy. Now, this graph shows something called progression-free survival. What progression-free survival means is you didn't die, and also your amyloidosis did not progress. So I don't want you to look at this and say all of these people died. The curves may go down just because they had progression of their light chains too. But what we see here is that in this combination, in this big group of patients, some of whom had this translocation, the 1114 that I mentioned before, and some of who didn't, you can see there's a pretty big difference in progression-free survival. This series also had the issue of some patients just got venetoclax, maybe with dexamethasone, and some patients got venetoclax in combination with other chemotherapy drugs. So how do we tease it apart? The answer is we look at the data for the ones who just got venetoclax with nothing more than steroids, and you can actually see that in the patients with the 1114 translocation, about 3/4 of them had a response when they didn't get any other chemotherapy added. Now, remember I said the patients with this translocation are the ones most likely to respond, but I can show you here that 2 out of 5 patients who didn't have the translocation and who got treated with venetoclax and dexamethasone also responded. So it's not like you can't respond to venetoclax, it's just that you're not as likely to respond to venetoclax when you don't have this translocation. So there is a lot of interest in studying venetoclax-based therapy in AL amyloidosis, particularly in the 1114 positive subset, which is about half of patients. These are studies that were found on clinicaltrials.gov, and you can see that the middle two are venetoclax in combination with other drugs that we use to treat plasma cells, like daratumumab in the second one, and ixatuximab, ixazomib rather, I apologize, ixazomib, which is a drug related to bortezomib or Velcade. These are ongoing studies, and the last study is a different BCL2 inhibitor that's also being studied. So I think a lot of promise here, and there is a tendency to think about venetoclax-based therapy in amyloidosis patients who've had 1 or 2 prior lines of therapy if they have the 1114 translocation. Now, the next thing I want to move into is this class of drugs here, bispecific antibodies and cellular therapies, and I'm going to focus on the ones that target something called BCMA. Now, BCMA is a protein on the surface of plasma cells. So, and it's pretty, you know, it's specific for plasma cells, so it's a great target. Other therapies that we use, like daratumumab and isatuximab, and there's another antibody called elotuzumab. These are other examples of antibodies that can be used to treat and kill plasma cells. BCMA targeted therapy is just another type of antibody that targets a different target on the plasma cells. Going back to these, like Dara and isatuximab target a protein called CD38. Elotuzumab targets something called SLAMF7. Well, what I'm going to talk about are antibodies that target BCMA. Now, The first BCMA-targeted antibody was was investigated and actually for a while FDA approved was something called the belantamab mafodotin, belantamab, and this has since been withdrawn. But I'm going to explain why. But this is an example of a type of antibody called an antibody-drug conjugate. These antibodies that I'm showing you here, the DARA, ISA, and ELO, these are just what we call naked antibodies. These are antibodies, they have this sort of barbecue fork type structure, and they bind to the plasma cells and trigger damage to the plasma cells or engage the immune system, but they don't deliver any payload themselves. Antibody drug conjugates have some sort of toxin or radioactive isotope or something like that linked to it. So when you plug this antibody into the plasma cells, it's actually delivering a toxin right to the plasma cells. And that's what belantamab is. But belantamab is off the market, despite the fact that it's very active in AL amyloidosis. There have been several studies reported, case series, which have 1 to 2 dozen patients in them, and the overall response rates with this antibody are in the 50 to 75% range. So the majority of patients treated with belantamab responded, including a lot of patients that had very good partial responses or better. So why, what's the downside? The downside is the toxicity. And there's a type of eye toxicity called keratopathy, and it happens in about 75% of patients. And sometimes because the eyes get very irritated and because there are visual changes that can last quite a long time, treatment interruptions are pretty frequent. Fortunately, because the drug is so active, it's common for responses to continue while the drug has to be held, but sometimes it can take a very long time, months, for the eye toxicity to resolve. This fact, plus the negative results of a randomized study, led to the drug being withdrawn from the market for multiple myeloma, which no longer made it active in AL amyloidosis. But it may be making a comeback because there were other randomized studies in multiple myeloma more recently which were strongly positive favoring this antibody. So I think it's generally believed that belantamab is going to be back on market, and when it is, we'll need to figure out how to use it in AL amyloidosis and multiple myeloma to minimize this eye toxicity. Now, there's another type of new antibody, not a antibody drug conjugate, but something called a bispecific. The reason it's called a bispecific is because the 2 points on the antibody target 2 different things. So instead of both parts of the antibody binding to the same protein, one binds to that protein, the plasma cell target, and the other one binds to immune cells called T cells, and by doing this, it engages the immune system in a very, very robust way. It brings the immune cells in somebody's body sort of right in close contact to the plasma cells and activates them and lets them, sort of turns them loose on the plasma cells. And the activity of bispecific antibodies is extremely high compared to the activity of the naked antibodies and even belantamab. Response rates in multiple myeloma that are in the range of 55 to 70% with these kind of bispecific antibodies. And these are the bispecifics that target BCMA. Teclistamab and elranatamab are both approved, and linvoseltamab is currently in clinical trials. All of these are or are soon going to be in clinical trials in AL amyloidosis. At Karmanos, we're going to have a linvoseltamab bispecific trial. I think the one that is furthest along, the last time I checked, is a trial of elranatamab. So these are all going to be studied in AL amyloidosis. Now, the other BCMA-targeted therapy that's available is CAR T cells. CAR T cells are your own immune cells taken out of your body and then modified to have receptors on them that bind a specific target. One of the ways AL amyloidosis plasma cells and also cancerous plasma cell, malignant plasma cells and multiple myeloma and cancer in general evades, one of the ways that it can persist and develop in your body is that it evades the immune system. But when you modify these T cells, these immune cells from your body, it lets them find the target, and it overcomes that resistance mechanism. There are 2 approved CAR T cells in multiple myeloma, and there's one NXC201, which is investigational and is being studied or has been studied and is still in ongoing studies in patients with AL amyloidosis. There was a publication of 16 patients, all of whom had at least 3 prior lines of therapy that had to have included daratumumab and bortezomib and other therapies. This trial permitted patients with very impaired kidney function, very impaired heart function. The majority of the patients had kidney and heart involvement. And another swimmer's plot here. At the bottom, P1 is the first patient treated, P16 is the last patient treated. So this is 16 patients over time. And every line that turns dark purple is a patient who achieved a complete response. And every line that has little yellow stars on it means that they became MRD negative, which means using the most sensitive testing that we have, we are unable to find any residual amyloidosis plasma cells in their bone marrow. 75% of the patients on this trial achieved complete responses, but there were specific complications. There are some immune and neurologic side effects with these CAR T cells. Very manageable, but somewhat more difficult to treat in AL amyloidosis patients than in multiple myeloma patients. And also because these patients had, on average, had lots of prior therapy and had very severe organ involvement, several of the patients on this study, I think 7 out of the 16 have passed away by the time of the publication. Several of them due to complications of amyloidosis, despite having a good hematologic response. No patients died of complications of the therapy, though. It was just somewhat bumpy at the beginning, but they all got through it. Right now, there's an ongoing study of these CAR T cells in patients who've had a bit less therapy, that we're using it earlier with a little bit more, I think, strategic selection of patients. And so far, this looks like an incredibly active agent in AL amyloidosis. Karmanos has this open and several other centers do. The lead center for this is Sloan Kettering. Dr. Landau is leading that. Last topic, and I'm going to talk about this quite a bit more quickly, are antifibril agents shown here. Remember all the therapies we've talked about, the Dara-Cybor-D that you heard about in the first talk, and the BCMA targeted therapy, the venetoclax, all of these therapies target plasma cells. Now, what about the strategy, instead of targeting the plasma cells so they stop making toxic protein, what if you just dealt with the toxic protein? That's what these therapies do. These are antibodies that actually target the toxic proteins, the misfolded proteins and the tissue fibrils that the plasma cells make. The 2 of them that are the furthest along are bertamimab, which used to be called NEOD-001, and anselamimab, which used to be called CAL-101. These target the fibrils. These also target like prefibril protein too. And the hope is that it will increase the number of patients that have organ responses and maybe help address that issue that we heard about in the first talk, which is even really good anti-plasma cell therapy doesn't seem to have an impact on early survival because of the way organs are already injured in some patients, and maybe we can fix that. There are 2 trials of anselamimab, which are basically it's Cyborg-D or Dara-Cyborg-D with or without this antibody being added in patients with different stages of heart function. These have finished accruing patients, and we're waiting for the results. And then there's one trial of bertamimab, which is either at the tail end of accrual or it may have recently closed. I'm not sure if it's still accruing, but they're in the home stretch, and it's a very similar design, advanced heart involvement, Cyborg-D based therapy with or without this antifibril antibody. And then we'll see whether adding the antibody makes outcomes better in addition to standard of care. Last antifibril therapy I want to talk about is one that is really exciting. It's called a pan-amyloid removal agent. And it turns out that, so like bertamimab and anselamimab, they're antibodies that target amyloid fibrils, but only AL amyloidosis, light chain based amyloid fibrils. So for somebody with transthyretin amyloid or ALEC2 amyloid or other types of amyloid, these antibodies would have no benefit whatsoever. There's some new work or newer work being done targeting other proteins or structures that are in the amyloid fibrils. There's something called GAGs, glycosaminoglycans. There's other things you could target in the fibrils, and some of them are present in any kind of amyloid fibril. So for instance, GAGs, those are present in all the different types of amyloid, and so an antibody that can bind to these structures theoretically would be active in AL amyloidosis and could be active in other types of amyloid too. And then, then you could apply the same kind of strategy that we're examining with bertamimab and anselamimab. You could try this across the board in all types of amyloidosis. So that's very exciting. So these are studies that are being done in 2 different types of amyloidosis, TTR amyloidosis and AL amyloidosis. This is ongoing work, and we'll wait to see what this shows. And with that, I'm going to wrap it up. That's my whole talk. Thank you.
Super. Thank you so much. Okay. We're going to get to our Q&A. Before we do, Bob, do we have Paula's presentation racked up, or she'll never speak to us again?
We do finally have it available. So let me share it here.
Hi, everyone.
Can we hear that?
Today,
Yep.
I will be talking to you about the different financial assistance programs that are available to help offset some of the out-of-pocket expenses that you may have due to your diagnosis of amyloidosis. I have listed several different charitable foundations who offer assistance programs that can help with copays, deductibles, premiums, diagnostic testing, and even some travel costs depending on the particular program. The eligibility criteria and grant amount for each of these programs is different, so you will need to identify which one will best suit your individual needs. I have listed off to the right side of each foundation the federal poverty threshold percentage that they use as their financial criteria. What you will learn today is these programs open and close several times each year based solely on the funding they have available at any given time. Please look at the yellow highlighted areas on the current slide. These funds are currently open. However, to qualify for the Healthville Foundation cardiomyopathy funds, you must be on Medicare. To qualify for the patient aid funds with the LLS, you must have a blood cancer diagnosis in addition to your AL diagnosis. I have listed several different funds that cover blood cancers, so please be mindful of those if you have myeloma, Waldenstrom's, lymphoma, leukemia, or any other type of blood cancer. This slide shows more foundations that offer assistance for amyloidosis and/or myeloma. I have also listed a pharmaceutical assistance link for the drug Darzalex, also known as daratumumab. They have a program that can possibly assist you if you are low income and are on Medicare, Medicaid, or some other form of government assistance. If you have commercial insurance and are not on any type of government assistance, you should inquire about their J&J with Me savings program that can reduce your cost to just $5 per dose. Keep in mind that most of our pharmaceutical companies normally provide some type of financial assistance program or copay cards depending on the type of insurance coverage that you have. I'm not talking about just your amyloid treatment drugs. This also applies to other supportive therapies like Farxiga, Jardiance, Eliquis, or any other newer prescription drugs you may be taking. Drugs that have been around for many years or have a generic alternative generally no longer have these assistance programs. This slide shows you the 2025 federal poverty levels. Each individual foundation sets their own annual income limit. Most are set at 500%, but others may vary between 300 and 600%. Let's use Healthwell Foundation as an example since they have a fund that's open. You are allowed to make up to 500% of the federal poverty level to qualify for their grant. So look at the 500% column and then drop down to the line that matches the number of people that are in your household. Let's say 2 for an example. You are allowed to make up to $105,750 annually. If you live in Alaska, Hawaii, or a large metropolitan area with a higher cost of living, the annual income amounts allowed are larger. Call the individual foundation to see what the limit may be in your area. So what do you do now to better your chances of snagging a grant the next time a fund opens? Most of these funds have an email wait list where you can sign up to receive notifications when the fund reopens. Apply as soon as possible because there is a lot of competition for these grants and the fund can close again at any moment. Keep your previous year's tax forms handy because you will need info from them when applying for assistance. I also suggest that you sign up for the Pan Foundation's Fund Finder program. They will email you when one of the various funds reopens. Additionally, if you have a blood cancer, be sure to sign up for those grant alerts as well. You can also go directly to the Fund Finder website and check to see which funds are currently open. If the lock is red and closed, then so is the fund. The example on your screen shows one green lock, which signifies that the fund is open. You then click on the organization's name and it will take you to their website. A link for the Fund Finder program and all others I have discussed today are posted in the chat for you to copy and paste, or you can email me directly at paula@amyloidosissupport.org and I will send them to you. Thanks so much for your attention today, and I hope you learn a lot from our wonderful physician speakers that are coming up.
That's great. Bob, if for some reason you can't post that in the chart, be sure to email Paula@amyloidosissupport.org and she'll send you everything that you need, okay? And now, if I can ask Dr. Zonder to show his face. And if I can ask both of you to unmute. Okay, I will say that we're going to take the questions that were emailed in first before we go, but some of them were answered so beautifully by your presentation. So, okay, for instance, the first one, you know, it's after Dara what, and I think that was handled, but maybe we can do a quick overview. This person says her husband is 83 and just finished 2 years of Dara chemo. Now they're wondering what else would be available for him because he's very weak and unsteady. And then another person we have, Bob and Pat. What is the recommended treatment for recurrence of light chains after initial treatment with Dara and 18 months following normal levels? What you know, I realize that you're giving free second opinions, and that's perfectly all right. But Dr. Zonder will take you first.
Well, first, I mean, probably the most important detail when thinking about next therapy is, how did a patient respond to prior therapy, and how long has it been? How did they tolerate it, and how long has it been since they've gotten it? I've definitely retreated patients with daratumumab before, or daratumumab-based therapy. So, for instance, you saw in passing, you know, if I had a patient who had gotten their 18 months of dara maintenance and had an 11-14 translocation, I might be thinking about venetoclax-based therapy, but I might be thinking about adding bortezomib or daratumumab as a partner for venetoclax in that patient. Um, Based on that 70% response rate that I showed you, and if a patient were frail, I'd probably be thinking about one of those things or the other. Like I might lead with Ven plus some Dex or Dara plus some Dex, and then think about, if I wanted to add a second agent after I saw sort of what happened. I didn't talk about some very standard considerations in my lecture. I was really focused on newer treatments. Um, but there are chemotherapy type, just standard chemotherapies. There's another drug in the cytoxan and melphalan family called bendamustine, which has real activity in amyloidosis. There's a class of drug called IMiDs. The one that we use most commonly in amyloidosis is probably pomalidomide, but lenalidomide is another example of that. They're not, they're pills, they're active for sure. They're not, they were developed for multiple myeloma, not as easy to tolerate in amyloidosis as in myeloma. But with appropriate dosing in the right patients, those would also be a consideration for second line treatment. But,
Thank you.
yeah.
And Dr. Akhtar, I see you nodding. So do you have anything to add?
No, I completely agree with Dr. Zonder, right? So this is it's like playing chess, right? So if you have something that's worked, and the patient hasn't been exposed to it for a while, you can retreat. I think we're very fortunate in amyloidosis that almost fortunate is probably not the word, but around 40 to 50% of patients are translocation 11-14, as Dr. Zonder was saying in his talk. So venetoclax has real activity. So trying to treat these patients with venetoclax is something that we do all the time in these patients, and then re-exposing them to drugs that they've been exposed to prior.
Dr. Akhtar, can I just, you talked about transplant in the context of first line therapy.
Yes,
I didn't just bring it up, but transplant, right? I mean, could be something that you
exactly.
think about in a patient who maybe deferred transplant in first line based on their response, right? Maybe not the fragile patient who asked this question, but in the right patient, couldn't you?
Oh, 100%. Yes. So that's why we collect stem cells up front. And then if someone is relapsing and they're still young, they're still healthy, they have a good heart, then definitely, you want to expose them to that chemotherapy, right? So absolutely.
Right. That's not going to help our 83-year-old, but for the
No,
average person.
no, I just for that context, probably not.
Right.
Yes.
Okay. Speaking of 83-year-old, he thought he was old. We've got Donald, who's 95. Okay. And he wants to, how do you treat his chronic kidney disease, peripheral neuropathy, all due to the amyloidosis? Okay. He's had 2 years of daratumumab and steroids. Then he was off therapy for 2 years and was reasonably stable. And now he's suffering a lot of fatigue, a lot of aching, a lot of weakness. He doesn't really say anything about how his light chains, whether they've been elevated, but let's assume that they are elevated. And he wants to know what would be next for a 95-year-old.
Dr. Zonder, do you want?
It's all you, Dr. Akhtar.
I beg your pardon?
Dr. Zonder will take this.
You want me?
Oh, he'll take this. Okay, go ahead. Yeah.
I mean, I'd be thinking first, Muriel, as you pointed out, in a 93-year-old or in any patient, make sure that the symptoms that the patient's experiencing can actually be attributed to amyloid, right? And that,
Yeah,
that it's
exactly.
something that, you just want to make sure that there's at least the potential to benefit from anti-amyloid therapy. I'd be thinking about antibodies. In a 93-year-old, when I think about like what's tolerable, I'd be thinking about anti-CD38 antibodies if they hadn't seen them before. I think daratumumab, in myeloma, the response rate to daratumumab is 30 to 40%. But in amyloidosis, the series that have been done of dara by itself, I mean, the response rates are twice that high. And so, it's just that the amyloid patients, because of their organ involvement and the symptoms they have, as a group, are more fragile than myeloma patients. But amyloid plasma cells are actually more susceptible to the effects of treatment than myeloma plasma cells. They don't really behave like cancer cells. In some ways they behave more like just plasma cells, right? And not cancerous plasma cells. And so you may be able to get mileage out of just a single agent antibody.
So putting our 95-year-old Donald back on daratumumab might be if it's an elevated light chain situation.
I can tell you in multiple myeloma, we have treated some patients in their late 80s with bispecific antibodies, and they have tolerated them ultimately. And once you're through the first couple of weeks with bispecific antibodies, it tends to be an incredibly well tolerated. BCMA targeted antibodies tend to be very, very well tolerated, and so if a patient's strong enough to just get through the first couple of weeks, there can be real benefit. And I've had quite elderly patients who've been able to be treated with those.
Okay, Dr. Akhtar, we're gonna give you a question about MRD. Okay, which is minimum residual disease. I don't know if we went over it.
I can talk about it actually.
Yeah, because this Leonard wants to know if it's diagnosed in a patient with cardiac involvement, stage 2 heart failure, is treatment recommended to eliminate the MRD?
Yeah, that's a fantastic question. So I know there's a lot of people here who might not know what MRD is. So MRD basically, it stands for minimal residual disease. And what it basically means is that you're taking a sample of the bone marrow and you're counting thousands and thousands of cells, usually at least 100,000 cells, maybe up to 10,000 cells. And you're trying to see if you can find a single amyloid making plasma cell after counting these cells, usually with very sensitive technology. And sometimes what happens is you can achieve a complete response, which means you take a blood sample, can't find any abnormal protein. You take a bone marrow sample, and you do find a few abnormal cells there. So the data for MRD, and if you are able to detect those plasma cells, that's called being MRD positive. The data for MRD positivity is much more robust in other plasma cell disorders like multiple myeloma. In amyloidosis, we really don't know how to use it yet for treatment. There was a study that was published, I think, from the Mayo Clinic some years ago, about 40 odd patients. And they did find that patients who were MRD negative seemed to do better than those who are MRD positive. But what they also found two additional things that when I read that paper, I was like, yeah, that's the between the lines thing. And one of them is that if you achieve a complete response, hematological response, 75% of the times patients are MRD negative, which is great. But if you are MRD positive, but you have a CR or you have a complete response, those patients actually do very well as well. So I think at this point, we are not in a stage where we know how to operationalize this. I think in the SWOG 2213 study that I was talking about, they are going to be looking at MRD by next generation flow, and we'll have more insight into that.
Okay, Dr. Zonder, you agree?
Yeah, I agree completely. I don't have very much to add to that. I mean, in myeloma, we know that being MRD negative means your complete response is likely to last longer, and so it translates into better outcome because your disease remains controlled longer from a specific line of therapy. In AL amyloidosis, responses tend to be longer anyway. So it's hard to know what the extra benefit is. And a common question that patients have is, I'm in a CR. I had a bone marrow biopsy to see if I'm MRD negative. It turns out I'm not. Should I do something different to try to get to MRD negativity? And right now, the answer is there is absolutely no proof that we need to do that in AL amyloidosis. And almost no centers would recommend intensifying or modifying therapy that otherwise seems to be working very well just to hit that MRD negative uh, sort of level. If you've achieved a complete remission on a certain therapy, you do not need to switch your therapy.
Okay. Now here we have Sarah. Okay. And she's a 20-year plus survivor. Okay. And with multiple myeloma and amyloidosis. Okay. Right now my numbers are 86. Now she doesn't say how it's measured. Okay. Whether it's liters or deciliters or whatever. Okay. I have lots of pain everywhere. What should be treatment in my case? Hope to hear your, okay. So we don't have full information here. I know, but basically, even without full information, if you can say something that might help Sarah. You don't often hear about pain with amyloidosis, do you? Or do you?
I mean, it depends on what they mean by pain, right? So do they mean like nerve pain, or are they like body aches from top to bottom? That would be unusual.
Yeah, we don't know.
The only patients with like generalized pain that isn't neuropathy pain, a handful of patients definitely who have like muscle involvement or muscle and joint involvement, not the most common type of organ involvement, but there's, I think all of us with amyloidosis practices, I think, have a handful of patients with that kind of organ involvement, and it can be uncomfortable.
Leslie has a question about bloated stomach. She wants to know if it's common to have a bloated stomach with AL amyloidosis. She says she looks 5 months pregnant. She has it in her heart, kidneys, and intestines. The amyloid is in the heart. Okay. She also has, I don't know what this is, SIBO. She takes Miralax, Linzeth, and Motegrity to keep her bowels regular. Does she have to just accept looking like this?
You want to
Probably
take
could have used a GI
Yeah.
person or a neurologist in on this, but we'll let you guys fake it.
No, I mean, this is a very common problem. I mean, Dr. Zonder might know this. This is what I deal with day in and day out. And, it's challenging to treat these people. A lot of times the bloating is because of fluid that collects, and the fluid collects because the heart is involved. It's not pumping as effectively. The fluid can collect because the albumin levels are low, so a lot of the fluid seeps into the skin. And I have a patient actually the whole weekend, that's what I've been dealing with. And then of course, what she means by SIBO is a small intestinal bacterial overgrowth. So these are all common problems, and they're taking care of them is a challenge. As I was talking about supportive care in these settings, and I work with my nephrologist, with my cardiologist to kind of come up with a regimen that is suitable for the patients. If you try to take too much fluid off, a lot of times these people are lightheaded, they can fall. So you have to really strike a balance. And I think with a lot of hard work and a lot of attention, a lot of my patients do end up feeling better. I don't know. And then especially once you start seeing a response in the treatment, the albumin levels go up and it becomes a lot easier to manage some of these symptoms. I know, Dr. Zonder, do you have any
Yeah.
tricks up your sleeve?
So I would just say, so if the patient's referring to bloating and distension because of bowel dysfunction rather than
Yeah.
ascites, which is fluid collecting in the abdomen, or anasarca, which is fluid collecting under the skin, I mean, there are approved antibiotic treatments for small intestinal bacterial overgrowth.
Yes.
Most internists and gastroenterologists would know about that. So I mean, you could try treating the bacterial overgrowth and see if it improves bowel motility. Um, Also, important to, I mean, patients can develop malabsorption and dietary. You should. I mean, I would do some sort of like diet challenges. I would look into, like, does avoiding dairy help? Have they developed like an acquired lactose intolerance because of mucosal infiltration by amyloid fibrils? Um, Also, I've had patients who've benefited from pancreatic enzyme replacement. Sometimes the pancreatic function is affected by amyloid, And if your pancreas isn't making the digestive juices it's supposed to, sometimes that's one of the contributing factors to um, like a dumping syndrome or a malabsorption syndrome. And so it's all these things. Like, amyloidosis can have a lot of different effects on the bowel. The treatments that we use can have a lot of effects on the bowel, and so it's nickels and dimes adding up for a lot of patients, and it's a little bit of detective work, a little bit of trial and error, and also, I mean, sometimes there's 3 or 4 different things contributing to bowel dysfunction, and you can address 2 of them, and 2 of them aren't as easy, but if you fix those 2 things, person feels better, so that's my approach.
Yep.
You agree? Okay.
Yeah, the most common problem that I have to deal with, right? Nausea, dysmotility issues. It's really frustrating for patients, and they're pretty challenging to kind of control oftentimes.
Okay, yeah, we have another question here about GI, and this kind of leads to another question that, something we see posted in our Facebook group a lot, where people think that some chemotherapies will help certain organs heal faster, which of course, as you point out, the chemotherapies go to stop the factory from making amyloid, and hopefully the organs will heal. But you pointed out, Dr. Akhtar, in your presentation with the Andromeda trial, that we saw organs healing much quicker with those drugs. So are there some drugs that once they bring you down to a complete hematological response, might the organs seem to heal quicker with those drugs?
Yeah, I think I'll try to be a little nuanced in this response. If you look at some of the older amyloid studies and you look at the median time to response, or the amount of time it took to get to an organ response from the start of treatment, in some of the older studies, it was as long as 9 months on average, for example, to see a cardiac response. And if you see some of the newer studies looking at daratumumab, which works pretty quickly, that time is shortened very significantly. In fact, there's some studies that say even 3 to 4 months, sometimes you can start to see a response. And there's a very interesting paper that was published a few years ago that looked at organ response after achieving a complete hematological response. And some of them said that once you, in that paper, for example, you achieved a complete hematological response, and almost immediately you started to see an organ response. Now, this doesn't mean that the heart is normalizing or the heart is improving significantly. It just means that you're starting to see an improvement in those numbers. And part of the reason that happens is because, in addition to causing damage by depositing within the heart walls, the light chains, the amyloidogenic light chains that are being made, are also directly toxic to the heart. So when you stop that production, it seems that almost very quickly you can start to see an organ response. The time it takes to get to the best possible response is still unclear. There was a paper that was published a few years ago that looked at time to best response for both renal as well as kidney. And it seems that you can continue to see an improvement even up to 2 years later. But most people have kind of achieved their peak response by about 2 years from the start of treatment.
Dr. Zonder, anything to add?
Well, I completely agree that newer therapies like daratumumab, like in the CAR T trial that we're doing, I mean, we're seeing complete hematologic responses, literally within a week or 2 sometimes with these new therapies. And so I think that's part of the explanation for more, I think, more
Quicker.
organ responses and faster organ responses. Our definitions of organ responses are sort of evolving. And I think we're gonna see a big change in the way we think about these. Right now, when we show the results of studies, we talk about organ responses as if it's just a yes or no. You either had it or you didn't. But what we know is, in terms of how patients actually feel, and what an organ response means. Like how big of an impact does a cardiac response have on survival? How big of an impact does a kidney response have on avoiding dialysis? What you'll see is the deeper, the better those organ responses are, the better it translates into the stuff that you really care about. You don't as a patient, you don't really care how how much protein there is in your urine as a number. You care about how much swelling do you have in your legs, and did you have to start dialysis or not, right? And so it's our responses are based on lab values, but in terms of what it translates into, I think we're going to start thinking about organ response the way we think about blood responses: partial, very good, partial, complete, and it's gonna let us, I think, understand the differences between different therapies quite a bit better.
Okay. Okay, Maureen had a question about CAR T, but we spoke about CAR T, so that one's answered. And organ recovery, you answered our organ recovery. We have a few questions on that, so that's great. Okay, this is an interesting question from Sandra. Do the treatments, so we'll assume your entire chart, Dr. Zonder, and that, do the treatments work for all ethnicities? So do we see a difference? I remember seeing an ethnicity study, I think it was by Dr. Vishali's group, Vishali Satriwala's group in Boston or something, but so let's hear, but do different ethnicities respond in different ways to various treatments? And we'll take Dr. Zonder, and then we'll take Dr. Akhtar.
The short answer is, well, there's no short answer to this question. Extrapolating from myeloma, it seems that if patients actually have equal access to equal care, they have very, very similar outcomes. The fact of the matter is, though, minority patients, African American people specifically, are historically incredibly underrepresented in clinical trials. So there is a lot of interest in the amyloidosis and multiple myeloma community, research community, in getting at this, but and making sure that we know this is true. And I would say we are much more conscientious now about making sure that the patients we're studying treatments in reflect, our population, and that it's not just, 98% white people, 80% white men on trials. We try to make sure that we have diverse patient populations in clinical trials now. So.
Okay, and Dr. Akhtar, anything to add on that?
No, I really can't. I mean, that's just, Dr. Zonder hit the nail on the head. I think it's oftentimes just an access issue. It really is. And if people get to a complete response, if people get access to these drugs and they do well on them, they do well on them, essentially, right?
Okay.
And if I may quickly just,
Sure.
if you look at the Andromeda trial, there went a lot of African American patients, for example, on that study. I think there was like 20% minorities, some Asians, and they seemed to do the same. They seemed to do equally well. There wasn't a difference.
Right.
Okay, so if all things are equal and everyone has equal access, everyone does equally well. Gotcha. Okay, here's a question from Linda on length of survival. What is the latest survival estimate for an AL amyloidosis patient with mainly heart involvement? What is the longest one of your patients with AL amyloidosis with cardiac involvement has lived after diagnosis and treatment? Well, you're both young, so you haven't been treating patients that long. So, but
Thank you for saying that.
No, I'm not just saying that because when I got into this business more than 20 years ago, Boston had treated people in 1994. I don't know if you guys were born in 1994. But and some of those people with cardiac involvement are still alive today. So I know that, for a fact that we've got patients, 30-year survivors, that were treated at Boston. But, you guys, even if you were alive, you weren't practicing back then.
No.
I mean, with all due respect, Dr. Zonder has a little more gray hair than I do. But I'm going to let him take this. I think the answer on survival is it's going to change, right? Because with newer treatments. But Dr. Zonder, go ahead, and then if I have anything to add, I'll
right.
add.
It is actually very, very hard to pin this down right now. But there's two, I think, things that we can sort of cite that tells us it's improving. The first is it has taken a lot longer to get the results of the antifibril antibody studies than we expected that it would, right? And so, and that tells us that the expected number of events for patients with advanced heart involvement aren't happening at the rate that we expected them to happen. So that's one hint. The other thing is a bit more concrete than that. So if you look at like the original cardiac, so we've known for a long time that the degree of heart involvement sort of correlates with prognosis, survival. And the more advanced your heart involvement is the day you're diagnosed, the statistical, it has a statistical impact on survival going forward. There are older staging systems and newer staging systems. And so like when you look at the original cardiac staging systems, right, you could divide patients up into, minimal heart involvement, medium heart involvement, advanced heart involvement, and you could compare the survival, and they were clearly all different. And then there's newer staging systems, like one of the latest ones is Boston University had one that used a heart marker called BNP instead of NT-proBNP, and they showed, just like Mayo had shown in the older systems, that more heart involvement had a negative prognostic impact. But when you look at the survival of the stage 3 patients in the high cardiac stage patients in the Boston system versus the survival of the high cardiac involvement in the original Mayo system, totally different, like duration of survival, much longer than it used to be. So we've gotten better at treating patients. I mean, patients stage for stage are doing better now in 2025 than they did in 1994 when the original staging systems were published. But there's still work to do. I think actually no, it was later than 1994, but it was, the point is we're doing better. It's improving.
Okay.
May I add a quick point to that, Dr. Zonder, if I may?
You may.
Yeah. I mean, Dr. Zonder knows this paper as well, but in patients who achieve a cardiac complete response, which means that your BNP is basically normal, the life expectancy is actually comparable to the general population now, is what we're seeing. At least there's some studies that are beginning to suggest that. But these are, again, people who are using older staging systems. If you get to a point where your markers are normal, you can expect to live almost comparable to normal life expectancy.
Right.
Super. Okay. Stem cell transplant question from D. How many stem cell transplants can an AL amyloidosis patient have? I've already had 2.
There's no cap on it per se, but most people, when they have stem cells collected, don't have more than 2 bags ever collected. And even in multiple myeloma, where more patients are a candidate for transplant, and where patients tend to go through therapies faster over time, only a very small minority of patients ever get more than even 1 transplant. Most patients who have a second bag of cells collected never use it. It's possible to do 2. It's possible to do more, but it's very, very uncommon.
This is an interesting question on essential tremor from Robin. I have essential tremor in my left hand. Essential tremors run in my family on my mother's side. Since I began weekly treatment for AL amyloidosis in August 2024, DARA, chemo, Dex, I assume the chemo is Cytoxan, but we don't really know, dexamethasone, 20 milligrams. I've noticed an increase in my tremors. Do you think this could be due to the disease or the treatments? The disease affects my hearts and kidney. And then I'm looking at, Dex. I know the few times I've had to take steroids for other things, they've given me energy and anxiety that I could have done without. So I'm just wondering about that, but I'll let you guys answer this.
You want to take it?
Yeah, DEX well known to cause the worsening of the tremors. So it's probably the DEX, and I think he just needs better control, maybe a dose reduction or better control of if he's on propranolol, which is what we use for essential tremors. Sometimes that can help make it better.
What is it that you use for essential tremors?
So usually we use a drug called propranolol, which is a beta blocker, but it should be used carefully in patients with amyloidosis. But that is the drug that we usually use in patients with essential tremor. Propranolol.
Propranolol.
And then sometimes just reducing the dose of the DEX can sometimes help. Oftentimes that's all I need to do, really.
Okay, and Dr. Zonder?
Yeah, I was going to say, probably the DEX out of all of the drugs being used. For most of us, in patients who are over 70 or who have edema or who have known heart involvement, we're starting with half dose DEX, and 20 milligrams rather than 40 milligrams, and even using that strategy, at least half of patients have to have DEX reduced further. In my own practice, honestly, I try to get rid of it as rapidly as I can. So we refer to that strategy as Cybor no D. We just try to get rid of it quickly as possible. So, yeah.
Get along, little doggy.
I'm a big fan of Cybernode. I'll tell you that.
Yeah.
Okay. Okay, we had some more questions, but they were duplicates of things that we already discussed. So if your question was not answered out there specifically, but it was covered elsewhere, you'll understand why. Okay. Now questions on depleters. Okay, we're talking about bertemimab, we're talking about anselamimab or whatever the heck that thing's called, that the KL101 drug. Okay, so KL101, what is the status of the clinical trial related to KL101? What is the differentiating factors between ATTR and AL amyloidosis that enabled ATTR to have an already approved drug that reduces the amyloid in organs? I don't know what that, I think that's incorrect. So, right. So assuming FDA approval of KL101, am I a candidate for it? And can I be hopeful that KL101 will restore my cardiac function? Current ejection fraction equals 55 to 60%. That's pretty good. Okay. Anyway, so do you want me to repeat any of that? What is the status of the clinical trials related to KL101? And will all people with cardiac function be eligible for it if it is approved?
Well, I just to reiterate what I showed on my slide, there's two randomized studies where KAL-101, it was patients would get standard of care therapy for newly diagnosed AL amyloidosis, and then there was a randomization, 2-to-1 randomization, means 2 out of every 3 patients would get the antibody, and 1 out of 3 would not get the antibody, and we're waiting to see the results. They're done accruing. And from what I understand, there's going to be a readout in about the late second quarter of this year, is what I understand, which means we'll find out, what the answer is to this question. If it's a positive study, presumably that will lead to the approval of anselamimab, KAL-101. But it's highly likely that it would only be approved in newly diagnosed AL amyloidosis patients who have the degree of heart involvement that was required to get onto these studies, which one was a cardiac stage 3A study, one was a cardiac stage 3B study. There's really specific lab criteria for those. And it might turn out one of the studies is positive and the other one's negative. And if it does, it will probably only be approved for patients who would have met criteria for the one study. So I don't think it's going to be immediately available across the board for everybody with cardiac involvement, if they've already been treated. And although there's no reason to believe it wouldn't help other organs the way it would help hearts, I don't think it's going to be just,
In other words, they'd have to have new trials.
Yeah, it's not going to be prescribable for every patient who has any kind of organ involvement, at least initially.
Right, so they'd have to have a new trial for stage, assuming it's passed for newly diagnosed stage 3, then they'd have to have a trial for stage 4, newly diagnosed, and maybe previously diagnosed, and these trials could be ongoing forever, but at least that way some patients would be able to get in on treatment if they take part in the trial. Right. I would now with the bertamimab trial being stage 4, and I know they're looking for, they call it events, but we know what events means. They're okay. So I would think with stage 4 people, there would be more events because they're sicker. So doesn't it make sense that no?
Those are different staging systems. I mean, if Dr. Akhtar, if you want to explain like stage 3A, 3B, and 4, I mean, you can. Why don't you?
Yeah, so basically they're using different staging systems. The KL 101 used the European modification where they're going by the NT-proBNP level, and a 3B is someone who has an NT-proBNP level of more than 8,500. So these are very sick patients. They have very high early mortality. And stage 4 is using the Mayo 2012 classification where you have an elevated NT-proBNP, you have an increased DFLC and an elevated TROP-HS, and the NT-proBNP level is more than 1800. So they're different classification systems. It's apples and oranges. So unfortunately, the results may or may not be easily comparable between the two.
Gotcha. Okay. And so Rob wants to know how does it look in Canada? Well, these drugs usually get approved in the US when they get approved before they get approved in Canada, right? So are we safe in telling Rob he has to wait and see what happens in the US first before he has hopes for getting approved in Canada, or what?
I mean, it's hard to predict the order that drugs might be approved. I mean, I mean, as an example, Andromeda, was an international study, and it was approved in Europe and the United States and Canada all at different times. So it's I think that the evidence generated by these trials, hopefully, if it's positive and is approved in the United States, I mean, presumably it would be approved in Canada as well. But
It's also cost because they have to negotiate with the Canadian government on stuff, where in the United States it's with our insurance.
And it's a province by province, right? I mean, it's not.
Oh, I didn't know that. That's interesting.
I don't think it gets approved nationally. I think it gets right. Isn't that correct?
I don't know it. That's very interesting. I mean, you're closer to Canada than I am, I guess.
Well, you're up in Wisconsin, right?
Not that much closer.
Okay. Do you see the Northern Lights, both of you? No.
Almost never.
Okay.
Almost never hear that.
Almost never. Okay. And Rob also wants to know when the amyloid unfortunately returns and I fall out of remission, what are the best treatment options? Would I be looking at a second round of cyber-D-Dara or go straight to stem cell transplant? Well, I know you don't want to say what Rob should do, but if you have a patient who leaves remission after cyber-D-Dara, would you put him on that trial that you have for stem cell transplant? No.
That trial is for frontline only.
Oh, frontline only?
Yeah,
Okay.
and I think we go back to what Dr. Zonder said, actually. I kind of completely agree with him that you want to see how long they've been off treatment, how they responded to the initial treatment, and sometimes you can re-expose them to those drugs. I'll usually check for a translocation 1114. If it's positive, try to get them on venetoclax. So it's a complicated decision. We have to take into consideration the disease biology, frailty, and the availability of clinical trials.
Gotcha. Okay. Leslie says, well, those of us who live hours away, she lives from a center of excellence, she lives 7.5 hours away, be able to utilize telehealth services after March 29th. I don't know what the March 29th date means. Do you?
I don't.
Yeah. So, right, for the last several years, basically since COVID started, telehealth has been permissible. During the
You're
height
getting a little lower, Dr. Zonder. Can you move closer to your microphone?
can you hear me okay?
Yeah.
Okay. At the height of COVID, telehealth was sort of approved for use, and actually, you could even do interstate telehealth. And then once COVID started settling down, they rolled back the ability to do interstate telehealth, so you can only do it with patients who live within the same state and who at that time are in the state with you. You can't, like a Michigan resident who is wintering in Florida, I can't do telehealth with.
Oh,
And the codes, the billing codes for telehealth expire either at the end of February or the end of March, and so far they have not been renewed. They have not. There's been no word about whether it will continue to be permitted after that, and so that's a big question that we're all waiting to hear.
oh,
We are a little worried about that in not just the amyloid community, but just in general telehealth.
sure.
I mean, hardly anything good at all came out of COVID, but I'll say that I'll insist telemedicine was one of the few good things that came out of it, because it's really made it easier for patients with rare diseases to get medical attention, that would otherwise be challenging.
Right. And we started our webinars because of COVID too, and the reach to our audience is greater. So yeah, that's two things that have, that have come out. Okay. Ursula, what are your experience? Will you discuss these, Dr. Zonder? Teclistamab in the treatment of amyloidosis. Do you apply any kind of maintenance therapy after the patient reaches a complete hematological response?
Wow. There is not enough experience in amyloidosis to know the answer to that. Right now, we don't even know the answer to that in multiple myeloma. Teclistamab is one of those bispecific antibodies that targets BCMA, super high response rates. The majority of complete responders are actually MRD negative responders. I mean, it's really, really effective therapy for some patients, and but quite immunosuppressive, and so infections can be a real issue. And like if you measure IgG levels, antibody levels in patients who've been treated with teclistamab or other BCMA targeted therapies, I mean, sometimes it's like undetectably low antibody levels, and a lot of these patients need prophylactic. All of the patients in our practice get prophylactic antibiotics, and many of them get IVIG, which is antibody infusions to keep their antibody levels at a good range. And so, clinicians have a lot of interest in figuring out the answer to this specific question: how long do you have to treat? And right now, like for instance, we have a trial open at Karmanos in multiple myeloma, where after patients have been on teclistamab for a year, if they've had a very good partial response or better, they are randomized to one of three strategies: continuing teclistamab at the schedule they've been getting it, stopping teclistamab altogether, or spacing out the teclistamab to some milder ongoing maintenance strategy, right? And all of those are things that are being done right now. It's the Wild West. We're everybody is sort of case by case making it up as we go what seems best for a specific patient. Hopefully trials like this will let us, will teach us what the best actual strategy is.
Thank you. Okay, we're gonna do a lightning round here, so to answer some more questions. Alex asked a question that has to do, will Medicare pay for Attruby and Amvuttra? And that is an ATTR question, so Alex is but the answer is so far yes, so there you go. Okay, my understanding is that KL 101 trial is looking at pay. You answered this. You said that even though it might work with other organs, that they'd have to do other trials for KL 101 in order to find out, get it approved for like kidney involvement, things like that. Okay, the chat wasn't disabled, Jason, it was us, but we fixed it. Okay. I have renal primary AL since 2005, tandem stem cell transplant 2006 and 2007, currently on Dara plus Dex for increasing blah, 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 blah. I want to travel to East Africa. Oh, cool. I will be on monthly Darzalex Faspro after May 23rd. My hematologist says I cannot get yellow fever vaccine since it's a live vaccine. Well, that's a first world problem, isn't it? Should I cancel my trip? Or is there any way to get yellow fever vaccine by getting IVIG infusions before vaccinate? Oh, wow, this is incredible. That's a great problem to have, Barat, really. What do you think, guys?
IVIG is not likely to
Yeah.
fix that problem. IVIG is basically like a bag of donor antibodies, and so for common things, IVIG, it's a bag that has antibodies against measles and mumps and rubella and COVID and flu and strep and all these common things that you would want antibodies to, shingles maybe, but it's not going to have antibodies against yellow fever. And so I don't think you could get a bag of IVIG and assume that it's going to be protective. And I do agree. These questions actually come up fairly commonly about travel, and that's a tough travel question. I mean, um, you know, if you're going to a country that mandates yellow fever vaccination, I mean, they might they might waive it if you have a medical reason to not be able to get the vaccine. But the question is, do you want to go? If you can't get the vaccine, I don't know how to advise you on that one.
Yeah, same here. The
Yeah.
IVIG is basically just pooling antibodies from a bunch of people here, and I can assure you most of them have not been exposed to yellow fever.
Okay, this person wants to know, all right, we've answered this question. How long do we stay on daratumumab? And so that was kind of answered pretty thoroughly, I think. How long can stem cells be stored for future use? I know of people that have had them stored for 10 years, but I don't know what you say.
So we had this question actually come up in I also work with the Transplant Registry, the CIBMTR. So someone proposed this study, and we don't know the answer, but we've had people who have had stem cells collected more than 10 years ago that are still engrafting and are still successful. So I think that this is a good problem to have, that you have people who are living more than 10 years, 12 years, 15 years after they were collected. But so far, the data that we have, or at least anecdotal evidence that we have, is that even if you've collected them more than 10 years ago, we're still being able to use them successfully.
Okay, during the Andromeda study, did you have any data on the MRD negativity?
I don't think they reported MRD negativity in the trial. They did not, at least not in the New England paper. Dr. Zonder, are you familiar with any MRD data that was presented after? At least on the original New England paper, there was no MRD data that was discussed.
So I can check, and I can see if there's any data available about that, and I can let you know. But I don't think so.
Okay, we already answered the CAR T therapy for AL amyloidosis. We can skip that. Janice, what is your question? Question 3, post-treatment and auto stem cell. Is minor muscular chest pain stemming from possible nerve amyloidosis? How is this diagnosed? Any way to protect easily bruised hematomas? Is this normal?
It's a complicated question.
Yeah, that's a hard question. Yeah, I mean, bruising, blood vessel involvement, and more rarely coagulation abnormalities in amyloid patients. Just like any other organ involvement, tends to be slowly resolving if it does. So I have, I'm thinking about a patient, and I'm thinking about her because I've given slide presentations where my splash page for the presentation is her eyes right after she had this throwing up fit, and she had bruising around her eyes, right?
Yeah.
And that's how we knew she had amyloidosis. That's what she was given a diagnosis of myeloma, but because of that problem, we actually realized that really what she had was amyloidosis, and she's been on daratumumab maintenance therapy for years and years, and with great disease control. Her light chains have been fine for quite some time, and still, every so often, when she coughs really hard or throws up or anything like that happens, she gets bruising around her eyes. Years later, I mean, she's been at this for 10 years. And also, just, I know you said lightning round, and I know I'm talking a lot. I'm sorry. But like I just meant, like, she's been on daratumumab for 5 years, because when she got daratumumab, she started it like when we realized daratumumab has activity, and she had already had a transplant, and she had already had other therapies, and I already knew after other therapies sort of like what I should expect in terms of durability of response. And so it's she's a great example of like a, case by case, for a newly diagnosed patient who's had a great response. I don't think anybody would be highly interested in treating longer than daratumumab than Andromeda did. But in a lady like this person, who I know after other therapies had a relatively short duration of disease response, keeping her on daratumumab has changed the course of her disease, right? So it made sense for her, but it wouldn't make sense to adopt as a general strategy to treat all my patients with daratumumab endlessly. So I,
And she had myeloma as well, right? So she
she had enough
questionably
plasma cells in her bone marrow
to
originally that
qualify as myeloma.
she was told she had myeloma based on her original bone marrow, right? So right,
Yeah. Richard. Heading to maintenance soon. Question is, troponin I high is down from 192 to 128. How long does it take for my heart to get rid itself of amyloid protein stuck to it? Well, we were discussing organ healing, so I think that's pretty much answered. What is okay, so we kind of answered that. Let's see. Stephanie, diagnosed, currently on 5th line of therapy with teclistamab, now with complete responses last year. Now stage 5 kidney disease. That's pretty much end stage, isn't it? And have cardiac, GI, nervous system involvement, wondering how much organ recovery has been seen. Well, let's see, she's been in complete response, right, since last year, but her kidneys are in bad shape. I would imagine she's on dialysis, right?
Or close to it, yeah. I mean, Dr. Zonder, I don't think we know the answer, right? I mean, we don't know.
Yeah, that's a tough one to answer. Okay. Did Andromeda study measure the organ function recovery rate, and you discussed that, and then such as heart ejection fraction? Well, you know what they say about ejection fraction. You don't really consider that all that much with amyloidosis. Give a
It
quick,
doesn't get better.
Dr. Akhtar, and why ejection fraction is not that meaningful in amyloidosis.
Oftentimes ejection fraction is normal. The concern is that there is an issue with the strain, with the way the muscle is contracting, and with the thickness of the left ventricle. And what you see when you do an echo in amyloidosis is oftentimes that thickness does not really change, but the strain improves. But I really like what Dr. Zonder said earlier, that the real way that we should be measuring organ responses is quality of life parameters. Like, are people actually getting better? Are they feeling better? That's what really matters. That's what actually counts. Just a 30% decrease in someone's NT-proBNP is technically a cardiac response, but if someone is still short of breath and they can't walk to the restroom, it doesn't really mean much. So they did measure, to answer the question, they did measure organ responses, and they used an NT-proBNP to do that.
Hey, is there any drug in
Thank you.
trial to target tumor plasma cells only? Can you differentiate normal from tumor plasma cells? I think maybe in localized, where you would have an amyloidoma, is that when you would measure plasma cells in a specific, like, I'm confused, but you're not, right?
No, so yeah, I mean, so far, to my knowledge, we don't have any markers that necessarily distinguish malignant plasma cells from normal plasma cells. Although we do have some examples, like for instance, BCMA expression it's, BCMA is on normal plasma cells. It's in MGUS, which is a pre-myeloma, pre-amyloidosis condition, and it's in myeloma and amyloidosis, and the expression of it does tend to increase as you progress from having normal plasma cells to malignant ones, but you still have it on normal plasma cells. So I mean, you can do testing that distinguishes malignant plasma cells from normal plasma cells. MRD testing is a perfect example of that. That's the most sensitive, like, example of, you can pick out one abnormal plasma cell out of 1 million cells analyzed in the bone marrow with MRD testing, but we do not have therapies that will target that one abnormal plasma cell and leave all the other plasma cells in the bone marrow that are normal alone. No, I'm not aware of anything.
Okay. Historically, doxycycline was prescribed post SCT. Oh, this was back when, okay. Is this still being done for fibril management? And is it effective? They pretty much debunked that, didn't they? They had that study that debunked that. Is there anything you want to add? No? Okay. Is there any
Well,
different?
Can I just say one thing?
Sure.
It's not, debunking isn't, I disagree with the word debunking.
Yeah.
Because it
Okay, I'll take that back.
It wasn't like,
Conspiracy theory.
our original use was based on the evidence that was available at the time, and there was some evidence, animal models and this retrospective Mayo Clinic analysis that suggested doxycycline would destabilize amyloid fibrils, and so it based on best available evidence at the time, it was used, and then subsequently there's been more evidence generated, including a randomized study that was small but done, in China, and more recent work in Europe that does not support the use of doxycycline. So it was something that looked like it was going to work, and then it turned out it didn't work.
Okay. Then we have Maria says, is there any difference in activity or efficacy between DARA and Sarclisa?
That's a really good question, and my concern with using Sarclisa in the current formulation is it's IV and it needs a substantial fluid load. It's not the fluid load is not substantial, but it's especially if patients are in active cardiac failure. So my preference is to use daratumumab, but we don't actually have the evidence that one is better than the other. Our institution, we avoid using Sarclisa in amyloidosis. We use it in myeloma all the time, but we don't use it in amyloidosis.
Okie dokie. Edith, after 2 years of DARA maintenance, then what? Monitor monthly and hope the light chain stabilize? Well, we would hope that the light chains went to normal after 2 years of DARA. And this is something we didn't discuss, the fact that if DARA doesn't work in the first 3 months, it's not going to work, right? And then you immediately change over to something else.
Exactly.
Right. So, but all right. So Edith, what would be the answer to Edith's question? After 2 years of DARA maintenance, then what? Monitor monthly and hope the light chain stabilize. Oh, she probably means hope the light chains continue to be stable. I think that's what she meant.
Yes, that's the answer.
Okay. And so that's what you would do.
Yes.
Okay. And Jennifer, I was diagnosed with kidney involvement, relapsed in the spring of 2023. She had problems with blood. She's now been diagnosed with MDS. All right, we didn't discuss MDS. Okay. How common is it for an amyloidosis patient to develop a secondary form of cancer? It's possible that I might have to have a stem cell transplant. And this would be not an autologous one. Okay. The first stem cell I had back in 2019 was autologous. So maybe we should, go over MDS a little bit, secondary cancers for people that, have amyloidosis. And so let's start with you, Dr. Akhtar, and then we'll go to Dr. Zonder.
Yes, absolutely. And I think someone had earlier asked a question if they could have more than 2 transplants. And one of the reasons that we don't want to do that is, these are high dose chemotherapy agents. They damage the bone marrow and they can actually lead to MDS. So in this gentleman or this lady who had a transplant in 2019, so about 6 years ago or 5 years ago, it's quite likely that chemo induced some DNA damage in the stem cells. and resulted in MDS. Most of the data we have is from myeloma, where the risk of that happening is around of any secondary cancer is about 5%, but of these treatment-related MDS and AML is about 2 to 3%. It seems to be a little higher as in patients who are of advanced age. So yeah, there is a real risk, and that's something that I talk to all my patients about in terms of the risk for MDS is real with melphalan. And so the decision to proceed to an autologous stem cell transplant is not taken lightly.
Okay.
I don't know if Dr. Zonder, would you like to add anything to that? No.
Okay. Jason finished the 18 months of DARA, has the translocation 1114. His light chains have been rising slowly over the last year, still within normal though. Reluctant to get off of DARA given the increase in his light chains. Would staying in DARA be an option, or what about adding venetoclax?
It's a hard question. I think that there's no agreement in the amyloidosis community at all. There was a great survey that sort of, I think, unmasked this issue. There was a survey of amyloid experts about when do you start treating patients for a rising light chain, and the answer was it was all over the place. I think most of us would not wait until the light chains get up to like 10. And many of us wouldn't let the light chains get back up to 5, which could be 50, depending on how the units. But I don't think most of us probably wouldn't start treating a patient whose light chains were rising within the normal range. That seems early, but if it is rising, it's somebody you have to watch closely. I'd be checking that person's light chains every couple months probably. I wouldn't be I wouldn't take my eye off the ball, but I don't think I would retreat in the normal range.
Okay, let's make this the last question. We do have some unanswered questions, but I want to guarantee you folks, I will send them to the doctors. They will answer them because they're afraid of me, and they will send the answers back. And I know that for a fact. Okay. So, okay, last question, Maria. What's the difference between multiple myeloma plasma cells and AL amyloid plasma cells?
That's a really good question. I think at the heart of them, they're both clonal plasma cells that are abnormally dividing in the absence of a stimulus. Generally, what we find is that in patients with myeloma, the number or the burden of plasma cells tends to be much greater than amyloid. These patients tend to have more genetic abnormalities. That's why it's harder to treat. And that's why when you take an AL amyloid patient and treat them with, say, bispecifics or CAR T, you can see excellent responses, much better than what we see with multiple myeloma, because clonally they're less diverse, which means that there's not a lot of heterogeneity in the cells. There's fewer clonal cells. They're easier to get rid of. So, but at the heart of it, it's the same cell. It's just behaving differently. The volume is different. The set of problems it causes is different.
And I'll just add that there is definitely some overlap. There are patients
Exactly,
who
yes.
have both at the
Yes,
same
exactly.
time. Like they really have myeloma-related symptoms and they really have amyloidosis.
Absolutely.
And there's some pretty solid data that even if you don't have myeloma-related symptoms, bone lesions and things like that, if when you're diagnosed, if your bone marrow has enough plasma cells that you would typically be in the range considered to have multiple myeloma, and that's just 10% plasma cells. If you're north of 10% in your bone marrow, that has real prognostic significance. You're more likely to go through therapies a little bit faster. The biology does seem to be a little bit different when you have a more proliferative, a more active plasma cell clone. So.
Well, I just want to say you two have been a great team today, and I think you ought to think about taking it on the road, okay, to more of our in-person meetings, okay, and we'll see you in St. Louis on March 15th, Dr. Zonder, and Dr. Akhtar, I'll be talking to you about your next personal appearance as well.
Thank you so much.
Oh,
it's
you're
a real
welcome.
honor to be with Dr. Zonder on this call. He's a world-renowned expert.
And
Thank you so much.
I want to thank you so much, and thank Bob and Paula who recorded that presentation for us. I'm already getting emails about it. So Bob will make sure that this webinar will be up on our website, amyloidosissupport.org. It'll be on our YouTube channel. I'll post it on Facebook. So everyone will get a chance to rewatch it, and people that didn't get to see it will get to see it. Please fill out the survey after this is over. That's so important for us. Stay safe. Remember, we're a phone call away or an email. Keep the phone calls earlier in the day. You can email 24/7, Muriel at amyloidosissupport.org. Stay safe, everyone, and thank you again to everyone. We really appreciate this. Bye-bye now.
Thank you. Bye-bye.